نبدأ بسم الله. This was a continuation of the lecture we had online about last week. But this is something we discussed with a female class. This is actually this is 7 and 8. So these are two lectures into one because the Alzheimer part is large. And it's very important that Alzheimer's is a very big important part of your lectures or your examination. So I'll just review this lecture as and then the concepts here. صراحة, and it's very important. There's a lot of MCQs from this lecture in specific. Now, you remember this case that we had? Who remembers the diagnosis? Makes sense. So it's meningitis. So how did we come up with this diagnosis? What was the key feature here? So the altered mental status. So he had headache or fever, but on top of that, it was altered mental status. That was the weird part of it. And when you have meningitis, what's the most important thing you need to do in the beginning? First thing you do is start antibiotics. What are the antibiotics we get? Ceftriaxone, vancomycin. طبعا you add the cyclovir as a viral and ampicillin depending on the population, but you only need to know ceftriaxone, vancomycin. Okay, what is the triad of meningitis, which is the three things? If you find it, you need to rule out meningitis. Nah. It's a triad, but we always say that the neck stiffness is not part of the triad. So it's headache, fever, altered mental status. If you have these three, then you have to rule out meningitis. Okay, you'll definitely get something as a case scenario, similar as it's written here, and then you need to say that it's meningitis, and then you need first thing to do is ceftriaxone and vancomycin, and then you do everything else. What is everything else? Mostly it's the investigations. So how do you investigate for meningitis? CSF sample. What do we call that? Lumbar puncture or spinal tap. Do you do it right away or you do something before? Perfect, mashallah. So you look at the blood first and then you go to the CSF because you also want to make sure that it's from the blood to the CSF, or even if it's in the CSF, did it migrate to the blood, so you do a systemic management. Exactly. Kerning size. So one is you stretch the neck, one is you stretch the knee. Which one is the neck and which one is the knee?
Brzezinski's the neck.
Brzezinski's the neck? Kerning, yeah. Because Kerning's the K was the knee. And then finally, before you do the lumbar puncture, what do?
You have to check for the
CT, because you don't, technically in clinical, you can judge before doing a CT, but for academic purposes, you always do a CT before lumbar puncture. Why? Because if there's any risk of herniation, because if there's a tumor, there's a mass, there's bleeding, if there's anything that is pressuring the brain, and you poke a hole in the back, the pressure difference changes, physics pulls the brain down. Okay, so that's very important to note. And that's real quickly here. We have this case. I know we mentioned the history already and the differentials or the details about the history. And this is also very important, how we know that the patient is at risk of infection. Okay, so we know that the patient has a risk of contact and exposure. How do we know that from the context? And if the close contact is usually in our culture, how is it written in the scenario? Hajj. So he goes to Hajj, a lot of crowded people. And the academics in the US or other cultures, they say college dorms. And any crowded place can make someone predisposed to getting an infection. So when you see that in the context, anything that is crowded increases the risk of infection. Okay. Now, if also we have incomplete vaccinations, and if we have immunosuppression. So what are the types of, how would someone be immunosuppressed? HIV, so any infections that would lower. What else? Transplants, because they take immunosuppressive medications. Corticosteroids, so any steroids that would also lower.
If they're taking any treatment for cancer.
Treatment for cancer also can lower the immunity. Someone wanted to say something else? Okay, and transplant, of course. That's very important. But can someone have a low immunity without actually having immunosuppressive drugs or transplants? Elderly, because the immune system slowly becomes weaker after the age of 50. And
Children.
children, because it's being built, mashallah, in the two extremes. What is one more thing?
Basic pride.
Yeah, but not to the point you get an infection. But I get you. And yes, your body becomes weaker. But diabetes. So uncontrolled diabetes is actually a predisposition to infection. Okay. Like we said, the past medical, surgical, drug. I'm just going through this, and it's very important to know meningitis pretty well. Physical examination. We mentioned this one is the, and this one is the Brzezinski. But what else we need to do? We need to find any source of the infection to enter to the brain. So the doors to the brain are the nose and the ear. And the ear, what do we call it? The infection? Otitis media. And the nose? Sinus? Sinusitis. So that's how simple it is. And then you need to inspect the whole body because sometimes you'd find these rashes. And this is a sign of bacterial. Yeah, so this is a sign of spreading to the body. When you see it as a bad prognosis, it means that this is a very severe infection and it's specific for? Exactly. Yeah, so when you see this, this is Neisseria. But I don't think we'll say it in the exam. And I think this is more clinical. But it's nice to ask. It's good, mashallah, you know it. Type, and when you have infection in the meninges get irritated and they cover the eyes, so you get photophobia. They cover the head, so you get the headache, and they cover the ears, so you get the phonophobia. So these are all very important things to localize when you have the meningitis. How do you investigate? We mentioned that we do the regular labs, find WBCs being elevated, and then you do blood tests to look for the infection in the blood, such as culture, gram stains and such. And then you do the CT and you do the lumbar puncture. And lumbar puncture is very important to know how to differentiate fungal bacteria, TB versus viral versus bacteria. Let's start with the last one. What's the major feature in fungal TB? The major one. Very, very elevated protein. Very high protein, this is fungal TB, unless you see something else. Okay? I don't want to say ignore everything else, but for academic purposes, high protein is key. What about viral? Almost normal, except for
Few lymphocytes.
so it'll be lymphocytic, and as I mentioned, it will be almost normal. Okay, and then bacterial, everything is going to be disrupted. You have high pressure because the bacteria is more tense, causes tense meninges. You have turbid, it's an unclean sample, while the others are relatively clean. And then the glucose is very low because bacteria tends to eat the protein, the glucose. And then you have a gram of course, positive because it's bacteria, and you have more neutrophils in the CBC. So technically, bacteria, TB fungal would have elevated protein. Viral would be almost normal sample, and if anything, it would be lymphocytic predominant, and then bacterial is going to be a disrupted CSF. Okay, that's very important because it might show you a CSF reading, and you need to label what kind of CSF it is. So differentials, technically anything can cause headache, can cause fever if it's for example inflammation in the head, enlarging tumor or a trauma in the head can cause headache. But technically, a triad is difficult to label as a different differential. That's why when you say triad of meningitis, you know that it's meningitis until ruled otherwise. And that's it. We said we manage it with vancomycin ceftriaxone. You add acyclovir to make sure that it's not viral, because viral takes time to appear, or the results for viral takes time to be completed. So you cover with acyclovir or antiviral just in case, and if the results come out negative for viral, you just take it out. And ampicillin is for elderly or young population to cover for other organisms. The next case was this patient. This patient was an elderly man and he has frozen shoulder. So his right shoulder does not really move much with his body. So he said shoulder, of course orthopedics. He went to ortho, he did treatments, he did procedures, he did even surgeries, and the shoulder is still not moving as it should be. And then the ortho said, I did everything I can, this is a movement issue, I'll take him to movement disorders in neurology. When he comes to the clinic, you notice the lack of movement, and you notice in the history that he has severe constipation. So what's the key feature here? So constipation, but also frozen shoulder. So an elderly with a frozen shoulder that's not really related to the anatomy of the body. So it's a movement disorder. And in neurology, what's the most important movement disorder? Parkinson's. So Parkinson's, what is Parkinson's?
Generation of the dopaminergic neurons.
Exactly. So it's a dopamine disease. So, and then you would have
difficult to start.
exactly. What do difficulty to initiate and move movement? What do we call these? Tremors, rigidity. What's the mnemonic that we use? Trap. So TRAP. What is T? Tremor, and mostly famous is the pill-rolling tremor. Okay, and the R is for resistance, so log-like movement. Doesn't really move with the joints. A is for akinesia or bradykinesia. What is bradykinesia?
It's like
Lower movement, difficulty initiating,
slow
movement.
walk march which is
Yes.
walk small steps.
Yes. So also they call it shuffling. So they can't really give much movement. But bradykinesia as a concept, it's poverty of movement. So they cannot give enough movement. So say there's an amount of movement, the more they use it, the less they can give. So that's why it's never slowness, it's never a slow movement. It's just a poverty of movement. So the speed is always the same, but you lose the amplitude. So instead of it becoming slower, it just becomes limited. So that's bradykinesia. It's the same speed, but the amplitude is lower. Okay? Bradykinesia, because speed will be always the same amplitude, but becomes slower. So that's not bradykinesia. Okay? And then we have P, which is postural instability. Okay? Postural instability is when they're walking because they have frozen gait, because they have shuffling, because they have all these features. They tend to do two things. Number one is when they turn, they don't have a lot of movement, so when they turn, they need multiple steps to turn. Or they tend to want to speed up their movement, so they just do a bigger turn. When they do that, they lose their posture and they fall. They really can't give, and when you're falling, you need to do a rapid movement to save yourself. So they lose that rapid movement, so that's why they have postural instability. But that's something for the progressed case, which means to say you don't see postural instability in the beginning. You see it at the end. If you see it in the beginning, it's a red flag for atypical Parkinson's. And atypical Parkinson's is a long list, you don't need to know them. Well, basically, the patient shouldn't start with postural instability, because if they do, it means it's a atypical Parkinson's. But physical examination, we mentioned some things in the physical exam when you're doing the Parkinson's, which is trap, but also when you see a patient and they're not having, they have bradykinesia in the face. What do we call that? Mask-like face or hypomemia. So they really can't produce any movement in the face, so they really can't produce any emotion. Okay? Investigations. How do you diagnose Parkinson's? Clinical presentation. So it's a clinical diagnosis. Investigations technically is not beneficial. You don't really need to do investigations. Why do you do investigations? Is to rule out atypical Parkinson's. So if this patient is clearly Parkinson's, and you manage and you treat and you move with the patient, they're not acting normally, they're not responding well to the medication, they're not moving as they should in the Parkinson's clinic, then that means there's something wrong. You go back and you investigate looking for other causes of this abnormal movement. Okay? And in this case, we do a PET scan, because PET scan is looking at the hypometabolism or the metabolism of the brain functions. Technically, when you do the PET scan, because the disease of dopamine, the dopamine dies out. And in Parkinson's, you can see that the dopamine is becoming more and more less active. Here, there's a dopamine scan. So you actually label the dopamine, you send it to the body, it goes up, and it starts to eat the dopamine. It doesn't eat the dopamine, it doesn't get rid of this area. But if it's normal, so it means it's highly functioning. Dopamine is normal, there's no issue in the dopamine aspect of the brain. That means it's not Parkinson's. It means it's something else. So we use PET scan to label abnormal Parkinson's or atypical Parkinson's, not to diagnose Parkinson's. And when it comes to differentials, this is something you really don't need to know, but vascular versus toxic versus metabolic, each one appears differently. Some only appear in the lower limbs. So Parkinson's, the lower limbs, upper limbs, they're fine. Some appear in one side, so the whole right side, the right arm and the right leg. That's more in the one of the vasculars. But it really is not something you need to know. But differentials are very important in a Parkinson's case. That's why diagnosis is clinical presentation, starting with bradykinesia, and minus any red flags. Okay? And this is the pathophysiology. If you noticed the pathophysiology, important. I think you got the pathophysiology in different lectures, but the most important thing here is the Lewy bodies. So Lewy bodies, do you know what Lewy bodies are?
Aggregations of alpha.
Yes, and do they only exist in the brain, or they can exist somewhere else? So they also exist in the gut. Because if you remember the scenario, we had the constipation. And the severe constipation is a red flag because that's one of the hallmarks of early signs of Parkinson's. And why do we link severe and constipation with Parkinson's? Because the Lewy body, go ahead.
I think I was just going to say the action of dopamine.
No, it's actually because of Lewy bodies. So the Lewy bodies migrate either from the brain to the gut or from the gut to the brain. It's different concepts, different theories. But the Lewy body causes degeneration in the brain. As you can see here, the end result is the new degeneration. When the GI migrates to the vagus nerve down to the GI, and it causes disruption in the GI functions. And that's why the patient has constipation. Okay? And this is the substantia nigra, and you can see where it is, how it looks as a cut. And the more diminished it is, the less potential of dopamine usage you have. So basically, you lose all the potential of dopamine in the body, and then you have to do an external or a different route of managing the movement of the patient. Now, looking at the management, you either give the management, which is the medications, take it orally, does the job, it goes away, and you give it again, or use a pump, which is kind of a monitoring phase, or the deep brain stimulation. Now, in the mild PD, we have a window, therapeutic window, and the management is always about the window. What do you notice as PD progresses?
The therapeutic window gets narrowed.
Exactly. So the window gets narrow, but the effect of your medication is still the same. So that's why the most difficult part of treating Parkinson's is always managing or adjusting the dose as disease progresses. And if you give too much, you get something called dyskinesia, which is chaotic movement. There's so much dopamine, it just needs to go everywhere, so the patient moves haphazardly. However, if we don't give enough, they have an off phase, and they just turn off. The body is off, body can't move. They're stiff, or they can't really turn or move, and that's disrupting, especially during sleep. Now, when we reach this aspect of advanced PD, you notice that it's difficult to actually reach this very small window. So we go to the next level, which is the pump. And the pump is similar to the insulin pump. So what does the insulin pump do? It's in the GI system. It reads whatever it needs to read, and depending on the reading, it gives more or less. So it kind of gives you a sustained level of treatment. This is similar because it reads the usual assessment of the patient, and then it gives dopamine in small doses throughout the day to make sure that the patient is always in the right form of management, not on off and not on dyskinesia. But of course, some patients cannot do this, or they are not, they don't fit the criteria to benefit from this management, or they unfortunately advance even more. And we do something called deep brain stimulation. Heard about it before?
Things to do it for the glucose balance and the subtowns.
Exactly. But what it is exactly? What is this?
They're stimulating the action of the direct pathway to initiate.
So you remember the direct pathway, direct pathway, and all these things. So when you lose the substances from the neurodegeneration, you need to give a different signal, and that signal is the electronic signal. It's also something we call the pacemaker of the brain. Similar to the heart, it reads and gives electrical shoots to surpass whatever is missing from the body. So it's a small battery in the chest, a very thin wire under the skin, and then a small incision with the GPS thing that they used in the surgery. You know how and where to input the device. And it's a very thin device. It goes in. Sometimes it causes a little bleeding, but that's not a big issue. And then it rests there and it gives different signals. Now, the only side effect we think of, or the only thing we think about in the DBS is it going to be beneficial or worse for the patients? The procedure itself is relatively very simple, very safe. Yeah, the risks of any infection or bleed is lower than 2% in some places. It's very advanced when it comes to their team. But the issue here is in the effect of it. And as you mentioned, we put the globus pallidus or other aspects of the region. Some patients need it, some patients would get worse on it. So we need to do a general investigation and assessment of the patient, because if the patient does not fit the criteria, then it would be worse for them. It would cause worse freezing, worse tremor, or honestly just sits there and does nothing. We know the patient population that's going to be benefit from this case, but unless that it's if we screen them properly, we know that definitely this is going to benefit and definitely this is going to not going to benefit, and that makes it move away from the side effects. Okay, and who knows the new way of treating using genetics? So this is if you read something, it's called lenti-victor. So you know how we do treatments with genetics using viruses? What's the concept?
Think of the virus, put it into the body,
Mhm.
goes to the cell, injects the genes into the host genes.
And then it changes or rewrites the genes. So that's exactly what's happening here. We inject the genetic material or embed the genetic material into the virus and then technically infect the person. And that virus would then infect the area, cause the changes of DNA, and then that would rechange how the area or the body reacts to the DNA change. There's someone who, as a professor in France, who did this research, and is an amazing research because, as per the trial, it gave people improvement in their Parkinson's up to 4 years, and they need to get another injection after 4 years. So that tells you that in the near future, you can treat Parkinson's with only one injection once every 4 years. And that's crazy. No devices, no medications, no nothing. So hopefully this guy does what he's doing and produces this. Then Parkinson's is a horrible disease. And if we can do something here, then that would be amazing. And then finally, we have this case. And this case is very important because that's why I left it alone. This is what we just did was a review. Whatever I focused on is things that are very important for you to properly understand for the examinations. And then we have this case. Who would like to read? Go ahead.
An elderly man presents to your clinic with episodes of forgetfulness. He mentioned that he does not want to worry his children by coming alone, but they are starting to notice some signs.
Mm-hmm. So what's the demographics?
Elderly man,
Mm-hmm.
forgetful,
And what's the key features? Forgetfulness. But what's the most weird thing about this? It's not just forgetfulness.
he's reluctant to accept.
He's reluctant, so there's a social embarrassment here. But when someone is reluctant and worried that his children is going to notice and all these things, what does that mean?
They're still, they still have their cognitive functions.
They still have their cognitive functions, but it's more about being aware. So he's aware about. Yeah, that's more advanced. But basically, he's literally aware that he's losing his memory. Of course, this is number one. It's a horrible thing to feel. You know that you're becoming weaker and weaker. But because he's noticing, he doesn't want his family to notice. So that makes me ask the next question. Why did he come today rather than last week, rather than last month?
He was hoping it's not a real thing or something.
Maybe, but there's a different answer.
It progressed to a point where it can no longer.
Exactly. Khas, he can't control it. He can't hide it anymore. Now it's becoming severe. And how do we say that? It's not about the memory, but it's about the function of the memory. So small things add, and if I misplace my phone, I can look for it and find it. Nobody's going to notice. But when it becomes more, when we asked him this, he actually said, usually I said that I need to go to the hospital because I made an appointment with my friend to see him, and I missed it. He called me. He said, "Where are you?" I said, "What do you mean?" And he said, you promised me to see me at that time or whatever," and I didn't attend. And I'm usually a person that is always on time, very organized. I have my schedule, so that's something that is weird and affects his function of his day. And this is something we call activity of daily living. Okay, so when someone has an activity of daily living affected, they start to affect their function in their lives. And when that function is disrupted, they usually try to find any source of help. Okay, what other questions do you want to ask to approach this case?
What kind of memories you forgetting?
The patient can't really tell you what kind of memory, but he's just forgetting. If I put my phone in the drawer, the next few hours I'm looking for it. I don't know where I put it. I have to look for it in the house. And when I make an appointment with someone, I forget that I made it. And when they call me, I say, "Oh, I know, but I'm coming now. I was late, but I honestly forgot it."
Get trouble speaking?
No trouble speaking.
Does his family recognize that he's getting more irritable over time?
They told me that I'm losing my temper more often.
Could we expect if anyone had something similar?
His dad had something similar around the age of 90.
When did he exactly notice that?
8 months ago. 8 months ago, he noticed that it started.
Any hallucinations or visual disturbance?
No hallucinations, no visual disturbance.
So suddenly or gradually was that a trauma?
Slowly, and it's slowly becoming more and more worse. Every 3 months, I notice something getting worse. No head trauma history.
You can make that examination.
Exactly, but this isn't the investigation. That's correct. MashaAllah alik.
Do you agree?
Do I drink? Perfect. That's a good, very important question. Yes. How much? Exactly. That's also very important. Once a day,
For how long?
5 years.
5 years?
Mm.
Once a day, what do you drink?
I don't know any brands. لا بس يعني what's important is طبعا
How
of
much?
course you mean alcohol بس يعني 1 cup. But why is it important that I'm saying every day versus مثلا social drinking? This different culture context, but social drinking is different than daily drinking or excessive drinking. That is a predisposing factor to Alzheimer's or other neurological diseases. However, social drinking, على كلام الأجانب طبعا, is by US data, it is actually protective.
Yeah, really. That have this thing.
No, so it's very good. It's bad.
Drug use.
No drug use. I said I drink يعني ما أنا drugs. Nah, just kidding. Any other questions on MG? Okay. So, did we finish gender and age?
You said elderly man.
Elderly man. So, elderly is from which age
65 onwards.
onwards? So, I can be 65. I can be 102. But it's very important to know the age in this case. Why?
The incidence increases. So if you're below 74, that's about 47%.
MashaAllah.
It's around 60 and 74, that's about 3%.
MashaAllah, exactly. Actually, if you reach age of 80, you have 50-50 chance. That's why you have patients or people that are above the age of 90 and they're amazing, and people above 90 that are kind of with some level of dementia. But it doesn't mean they have severe dementia. It just means that they have a level. It can be mild, it can be very severe. And the difference here is the level of taking care of themselves at a young age. But the age is very important because anyone below the age of 70 would be labeled as a young onset dementia. And young onset dementia has a different pool of the diagnosis. It can be Alzheimer's that started early on, but it also means that you need to rule out anything. So if I say 74, you'd be more comfortable saying this is Alzheimer's and move forward. But if I say 65, 67, something below the age of 70, you would then be fearful that this could be a abnormal or an atypical dementia. And this is very important because we either have reversible or irreversible ones. Irreversible ones, unfortunately, tend to progress very fast, and the patient would have a bad prognosis within 3, 4, 5 months or years. They would unfortunately be very disabled, or they would be reversibles. And reversible dementias, yeah, haram we miss it. Okay, they always mention something in the examination for a young patient. let's say 50s or 45, and he has severe dementia, and you want to rule out a reversible cause, and it's something that he likes to do as a hobby, not a hobby, but he likes to do it recreation.
Sexual history for
Exactly. So this is for the young reversibles if we treat the infection, but the infections are negative in this case. Boxing is important because it causes neurodegeneration. Wernicke's. So these are all the young onset that needs to be ruled out. Patients that drink a lot also can present with Wernicke's encephalopathy because of vomiting and vitamin B12. But this was a patient that uses to sniff glue or sniff gas. So sniffing gas and glue is something that some people do apparently, and it causes dementia, and it's reversible. Okay, so these are the things that just is weird, but you need to think about. And knowing the age that is younger than 70 opens your mind to all these possibilities. There are a lot to the point in our way of clinical, the guidelines for us. Unfortunately, it's a lot of waste. But what we do is when someone is younger than 70, we just send out a huge list of investigations. We admit them for one day and we take all the samples and we do this huge list. Technically, we need to be focused. Method infection, if infection is negative, you do oncology. If it's negative, you do everything else. Like, because the brain is so precious, you just want to send for everything, make sure that it's negative. If it's negative, you go to the next level of looking for other findings. In 2 days, I have a huge list of investigations that I only need to know if it's there or not there, to know if it's reversible. And we actually do have patients that are reversible dementias. Okay? Onset, course, duration, all these things we mentioned. Baseline is also important. So the baseline of a patient, how is it different for someone, let's say, who's high functioning, a big lawyer, has a lot of clients, does a lot of writing, a lot of reading, a lot of calculations, let's say, financial calculations as well, versus someone who's just a regular guy, retired, chilling at home, doing not any, just living.
People with more cognitive demanding lifestyles tend to have less risk for Alzheimer's.
Yes, but also there's something extra.
You need to modify this lifestyle.
You use more brain, so you tend to, inshallah, save yourself from all this. However, if it happens, yes, it's fast, and it's not faster, but it's more important because when they get Alzheimer's, the benefit becomes the negative aspect because they're more protected. But if they get it, they have more cognitive reserve. They have more brain because they use it. Someone who's retired, chilling, doing nothing, he has an average brain. So when the brain decreases by 5%, you would notice it. But in a high functioning person, if it goes down 5%, he's already high functioning. You don't notice it until it goes down 20%. And unfortunately, these people have worse prognosis because they tend to come in late. So the baseline is also very important. Triggers, no triggers were there. We all mentioned good triggers, hitting his head, drinking, drugs, all these things are very important, infections. And the key features we mentioned. Now, again, when we look at the events and features we mentioned, but when we look at systemic findings, we look at the system. What are the most important organs we need to look for? The big ones are?
Thyroid.
Okay, thyroid and? Tell me the organ. The kidneys. Yes. And tell me another organ. Liver. And one last one. If you're in love. The heart. طيب, how does the heart cause something like dementia? So vascular dementia, how does it happen? Because of hypertension or clots and microangiopathic changes. So remember the imaging when I showed you the 11 sign, which is small white dots in this region? That's microangiopathic changes. Small hits that accumulate over time and cause dementia. Or as you mentioned, the vascular dementia, which is the type of dementia that basically because of strokes, because of vascular issues, clots, whatever, the vessels are not that high functioning and the patient would start to not get enough oxygenation. But also if you have, let's say, severe cases such as cardiac arrest, you stop blood to the brain and you have severe hypoxia. Depending on the length, you would destroy some part of the brain, and that makes it easier for someone to have memory issues or cognitive issues. The liver and the kidneys are for cleaning the body. So if you don't clean the body, you would have an accumulation of metabolic disturbances, and that can easily cause someone to have changes in his cognition. Again, these are all aspects of forgetfulness. So metabolic changes, toxic levels, all these things. Um, Thyroid is very important as well because hyper or hypothyroid can cause an aspect of cognitive issue, but not that huge. Constitutional symptoms is looking for cancers. Yes, night sweats, B symptoms, fever, and all these things. But so cancer is very important because cancer also can be a mimicker of dementia. And it's not rare, or it's not common, it's very, very rare. However, it can happen. So if in 100 patients you get one patient that is labeled Alzheimer's, but then if you approach them very well, you find that they have constitutional symptoms, thus finding cancer, and then treating the cancer and gaining back some sort of cognitive domain, that is a significant success story. So always be systemic. And we also had some patients who unfortunately were labeled as Alzheimer's for many years. And when they came to us, we did a proper approach and we found that they have different diseases and they were actually reversible. Like these are important things in life to make sure that they're not disrupted because they play a role in the history. Quality of life. Someone who has a bad quality of life would tend to have more depressed, anxious, some sort of mental health imbalance. And when you have some sort of mental health imbalance, you might have severe depression, which is a type of dementia, and we call it pseudo dementia. So pseudo dementia is when you have Alzheimer-like features, but the main difference is in the scenario. In pseudo dementia, someone doesn't notice that they're forgetting. They have so much lack of insight in life, and in such, they have a lack of insight in their forgetfulness. So they seem like dementia, but they're just very depressed. And that's the pseudo dementia. But
Alzheimer's itself causes like dementia. No, I'm sorry,
depression. Yes, but that's in the severe cases. And I'll get to that. But basically, in severe Alzheimer's, you tend to lose your brain, gets fried, and it's already dead. And whatever is left is the mental health. So the mental health starts to get disrupted. But also, if we have other mental health issues that are anxiousness, issues with focus, ADHD, stressed life in work or in Hala. And how many of you once had to go to the parking, look for your car, and you can't find it because of how stressful the day was? It happens, huh? Is that dementia, Alzheimer's? No, alhamdulillah. But that's one type of memory we call the working memory. And that's unfortunately why we have a lot of patients who started to come at a young age, around 30s and 40s, trying to look for Alzheimer's and doing images or labs because now we have advanced imaging and advanced labs to tell you if you're at risk or not. So people are afraid that they are having a risk of Alzheimer's and they don't catch it enough, and then that's affect their life. Especially now that we have different managers that can benefit them. There is a difference between Alzheimer's dementia and issues with memory. Mood, we mentioned it. ADLs, activities of daily living. So activity of daily living are one of three things. Either they're using their phone and they're having issues. So daily living is using your phone, using your finances, paying rent, paying at stores, using cash, using credit card, taking money from the ATM, putting your PIN code. And the third one is a routine that they used to do and they stopped doing it. So when they're using their phone, usually they would say if they have trouble calling a number. Because usually before the phones had buttons, but now they have screens. So now we changed how we ask this. Is if they enter the wrong conversation in WhatsApp, because there's no more buttons, but there's no more interaction with buttons. So if they speak to someone else, if I want to text you and I text them instead, and I make this mistake often, or if I say if the amount of word that I use is less. So there are some people in WhatsApp, they always text and send a lot of messages and they send long messages. Now, if you notice that their messages are becoming shorter and shorter, that's a red flag for the activities of daily living. When it comes to finances, if they miss their rent, if they pay the wrong amount, they take out 10 riyals, but it's 100 riyals. If someone gives them the rest of the money back and it's less or not accurate and they don't notice, these are small things that are activity of daily living, and a routine is something that they used to do. So this is very important, as what you mentioned, is when the mental health aspects happen. When someone has issues in their cognitive domains, what are the cognitive domains again? So memory is one. What else? Calculations, okay. Language. So that's generally, but see, you have to be, we can say executive function, making decisions.
Awareness.
Spatial awareness, we're going to come back to this, but this is not cognitive domain, but it's more of an orientation, okay?
problem solving.
So that's all executive function as well, and attention and all these that we just mentioned. Before, if the activity of daily living is fine, so they can function properly in life, then this patient is not Alzheimer's. We call them MCI, mild cognitive impairment. So one of the cognitive domains is affected, but it's in a very limited way that it's not really affecting their quality of life. They can still continue to do whatever they're doing. And we label them MCI plus whatever the cognitive domain is.
This is really late, but when we ask the patient, shouldn't we ask them if they're forgetting old things, just new things that they're going through?
That's a very important thing.
Retrograde amnesia, or if they're taking certain drugs that can cause it.
Yes. So when we come to diagnosis, part of it is clinical, and when you notice that if there's drugs or other conditions, you want to label out or rule out if they are contributing to the dementia, definitely. So when you look at the old memories, this is when we do the the physical exam, which is more of a MOCA examination, which is the mental state examination. It's bigger than the mini mental state exam, and that has concepts where you look at events, old episodes, even things that are relevant. So if we tell them, why did we start to use the if I point at my mask and I ask you, why did we used to use our masks? What would you think? Corona, COVID. So this is an event that is many years ago, but it's relevant to us. If you ask about the kings in who's the current king, it's a mnemonic or semantic memory. But these are the type of memories that we ask and look for. Sometimes the old memory is very important to look for, but it depends on the state of the patient. Now, if we go back to the ADLs with MCI, once the patient has an issue, and this is why the patient actually came, because he's not functioning well, and he needs some help. If you do your examination and you notice that or you do the history and you notice that the ADLs are affected, unfortunately, officially, he is Alzheimer's. Okay, so ADLs affected, Alzheimer's. ADLs are fine, MCI. Okay, and it's important because MCI, you can stop them from progressing to Alzheimer's if you fix whatever the risk factor is. But if they're Alzheimer's, they're one of three: either mild, moderate, or severe. Mild is when they have clear cognitive issues, one of the domains, especially in the memory, and it's actually stopping them from doing their activity. So if they're a teacher, they stop teaching. If they're working in a financial job, they stop working, and they can still do their routine tasks. However, when it's moderate, it becomes too severe to the point that they need someone to help them in these tasks. They really can't function alone. So that's the difference between mild and moderate. And severe is when the brain is fried, unfortunately, full neurodegeneration, and whatever is left is the mental health. So that's when they start to have depression, anxiety, all these things. And we stop treating the brain because there's no brain left to save, and we start treating their mental health. So we focus on anxiety, sleep, and depression and everything else. Family perspective is very important. You need to have the family on board because they will tell you different things because the patient can't really collect the information. And finally, most importantly, is visuospatial, which is a hallmark of Alzheimer's disease. So what is visuospatial?
Like where you are in space, feeling oriented, what you're doing, certain activities that require like coordination.
Exactly. Not coordination of movement, but coordination of path. So where you are in the space and where you go. So when you come to the university and you know the name, this is M3, MS13 or whatever it's called. If you know that your class there, you can go up. Right? Now, if you lose the route, that's visuospatial. So your vision and your space are not coordinated together. You don't know where you are. To the point that even if I bring you to this room, and I tell you, is this the classroom that we usually teach in? You can't really get that orientation. You see it, but you really can't understand that this is your room. Okay? So with that context, how would you notice in a female and how would you notice in a man if they lose visuospatial? You want to look for a usual route that they have. So what's a usual route, let's say, for a man? But he's retired, you work for multiple things. To the fridge, definitely, but everyone eats. And masjid, exactly. So masjid route is very important because when they start to lose their route, either they go to the masjid and they don't know how to come back, or they can't go to the masjid. Start noticing small questions. He makes his son actually force him to go to the masjid. They start to make up stuff for now. I don't like how you're praying at home. I want you to pray with me in the masjid. So these small things matter because they're initially the building blocks, unfortunately, of Alzheimer's. In the female population, what would be the aspect of visual spatial? So usually more it's in the house because usually they take care of the house, so they know everything in the house. So if they start to lose the pattern of how they maneuver through the house or how they do routine things in the house, that's also a red flag. There was a movie called Alice. It's a famous movie, very famous actor. I think it's 5 years ago about Alzheimer's. Anyone saw it? Okay, so basically, she used to live alone. She was divorced. She got Alzheimer's symptoms, didn't tell anyone. And then when it became severe, she told her family and her divorced the husband, her ex-husband. And then it became so severe that her family moved in inside the home. It became so severe because she was looking for the bathroom and she went to different rooms. She went to the closet, she went to the kitchen, she went to her bedroom, and she couldn't figure out where the bathroom was in her house. And then she couldn't hold it anymore and she let it go in the closet. So that's horrible to think of. But I'm just giving you this example because unfortunately this is what visuospatial does. You're in space, but you really don't know where you are. It's very frightening. It's very anxious driven. So visuospatial is unfortunately a hallmark of Alzheimer's. Okay? We went through the history, we went through the neuroaxis, cortical, of course, physical examination. We have the MoCA and the mini-mental state. MoCA is looking at the cognitive domains, visuospatial, the executive function, the attention, the memory, all these things, question by question, and then you give an overall score. MoCA is used for diagnosing if there's a cognitive disturbance or not. Mini-mental state is what you do every few clinics to notice if the patient is deteriorating or stable. Okay? You really don't need to know the MoCA exam, but it basically is questions around the cognitive domains. And then, again, there's no neurological investigations. There's no general investigations. It's a clinical diagnosis. And I mentioned the diagnosis by the ADLs. So you do the imaging, but it's not for diagnosing. You can do it for prognosing, for assessment, for other things. But generally, if we do any intervention, it's to rule out atypical features. So we want to make sure that this is Alzheimer's, it's not something else.
Doctor, can you do a biopsy of the brain tissue?
Yes, but what do you want to look for? Yes, technically, but it's invasive, and why would you want to do a biopsy? At the same time, most of the things is Alzheimer's, and that's why we know about the plates, because they do post-mortem studies. They cut the brain, they study the pathology after the patient dies. But now we have something called amyloid scan. So you do an imaging. So now, and until you skip the part, basically this is what I want to tell you. Before it's clinical, so you get a patient, you study them, khalas, this is Alzheimer's, if there's no red flags and everything else. Now, it's different. And now, I mean, a few months ago, we have an imaging where you literally put the patient in the machine and you see the amyloid in the image. And if the image has amyloid, then this patient has Alzheimer's. If the patient doesn't have amyloid, this is something completely different. This is something new. Yeah, and if your exam was last year, it wouldn't be there. But even this year, it's because it's still not part of the usual practice. But now there is an investigation for Alzheimer's. It's not a guessing game or clinical game anymore. Of course, also we have a blood test. You take a blood test and you find the ApoE, which is part of the Alzheimer's pathophysiology. And if it's positive, that tells you this patient has Alzheimer's. So now we have a blood test and now we have an image. Before, we didn't used to have that. However, if we go back to the academics before we look at the new advancements, if we do an imaging, we look at two regions. Again, this is not diagnosed, so it's helpful. We look at two things. If you notice, the atrophy is in a specific location. The moral, where is it? But this hallmark.
Oh, it's kind of sulcus.
Sulcus.
Mustache.
This is the
Location. It's from the neuro imaging.
I call it something else.
Not the mustache.
No, what's the question? What's the question?
What's this? Why? Sylvian
Fisher.
Fisher. So that's very important. Sylvian Fisher is by literature is the most accurate way to know if this patient is at risk of Alzheimer's or not. So it's the point that if you do CT, it gets deeper. So the more widened it gets, that tells that the patient is at risk of developing Alzheimer's. So for example, a patient comes in with headache or whatever, or stroke in the ER, and you do CT, and you notice that the sylvian fissure is wider than normal, that tells you that the patient might be predisposed to Alzheimer's. So that's crazy. But also you have the hippocampus because it's the area of the memory. When you do PET scan, you look at the energy of the brain. Depending how the energy is focused on, or the hypometabolism is focused on, temporal tells you more Alzheimer's, occipital tells you Lewy body dementia, frontal tells you more frontotemporal dementia. But we use it to differentiate from other atypical dementias. Differentials, technically anything that can disrupt the cognitive function of the brain, whether vascular dementia, as you mentioned, whether it's toxins, drugs going to the brain, metabolic disruptions. Some neoplasms can cause some disruption in the cognition. Anything technically can give you dementia, but that's why it's a clinical diagnosis of ADLs, activity daily living, MOCA exam, and no red flags. If there's no red flags, then technically you're safe to label the patient Alzheimer's. Pathophysiology, you can notice that everything on the right side can cause atrophy, especially aging. So as we age, unfortunately, the brain becomes smaller and smaller. But what we can do is we can treat the brain by giving it mental exercises, eat healthy and whatever. But then you have other parts of other things that cause deterioration. You don't really need to know them, but you need to know two things. The amyloid plaque and how it disrupts and accumulates, and the tau protein and how it becomes an oligomer that finally becomes a neurofibrillary tangle that becomes stuck to the neuron, and then it causes degeneration to the neuron. And this is also a part of how the amyloid plaque is created. And but I think the female class told me that you already studied amyloid plaques and tau. Yeah, so you know it pretty well. But for me, all you need to know that from pathophysiology point of view, it's caused by the tau and the amyloid plaques. Parkinson's is caused by Lewy bodies, or the alpha-synuclein, but it's also the Lewy bodies. And that's it. This is lecture 7 and 8. 7 and 8 was 7 is the meningitis, and 8 was the Parkinson's and the dementia. Okay.
So we're done with CBS.
Okay, then we're done with the CBS. And I didn't mention this, but it's 2 lectures in one. And it's a heavy content as opposed to the previous ones.